why do, like, this would be a strange one, but why would dogs always have an obsession with brooms? Like, even my dog, when I was like cleaning up at the back, it just like, as I was brooming, it's just like, I got to kill that thing.
Yeah, I have no idea. Toby's not fast. Indy wants to murder them.
Yeah.
And I think when we mentioned that to the breeder one time when they were going to boarding there when we were going on holiday or something, the breeder actually said to us that Indy's dad was exactly the same. Like he had a real thing for cleaning implements.
Yeah. It's so strange. Like, do they think it's like a rabbit or?
I have no idea.
Yeah.
She's not chill with it.
Because it's like it's across a lot of dogs that just want to get after the broom or whatever.
Yeah.
Like, it's such a weird thing. Yeah. Anyway.
Welcome to the podcast.
This production was recorded at the podcast studios in the Media Arts Centre at Murdoch University. The views and opinions expressed in this podcast are solely those of the hosts and guests and do not necessarily reflect the official policy or position of Murdoch University. Any content provided by the hosts and guests are their personal opinions and are not intended to represent the views or opinions of the university, its administration, faculty, or staff. Now we have that out of the way, let's talk science. Paramount importance.
All right. Well, let's segue into OCD. So, you're being a doctor, you're a GP, and then in the last few years, quite a few years, you've segued now into OCD WA. You're the co-founder or founder of OCD WA.
Yeah, I'm calling myself now the founding director.
The founding director, okay. And shedding light on OCD because it is a term that is loosely thrown around a lot. But can you explain what OCD is?
Yeah, so it is a neurobiological disorder. Some might argue that it's neurodevelopmental. I think I've probably had it my whole life. But essentially it's a mental health disorder that's characterised by having sort of recurrent distressing obsessions and or compulsions that you feel driven to do, and they're sort of fear-based, they're time-consuming and they're really distressing. So when you hear someone say, I'm so OCD because they like their pens lined up or, they like to do things a certain way, I always want to go back to what's the process underlying it, because if it feels good, it's not OCD. OCD is distressing, and for the diagnosis you have to have like clinically significant distress associated with it. So it's a really, really significant disorder that is undiagnosed in a huge number of people. When people have been diagnosed, they're not necessarily able to access the right care for it. And that, contributes to it being a really disabling disorder as well. So it's consistently ranked in the top 10 most disabling of all conditions by the World Health Organization. That's including cancers and, other awful conditions. And I was recently doing a little bit of research on the numbers in Australia, and it's the top ranking disorder for young people, especially young girls. It's ranking number 1 in terms of disability adjusted life years. So it's a pretty significant disorder.
Why girls? Why is it more?
I don't know. Yeah, it's more frequent in girls. I don't know if that is because it's better picked up in girls and the numbers are more similar than we think. It's not a huge discrepancy between boys and girls. But yeah, the female population does tend to be affected sort of more frequently.
Is it more of a recently, not discovered isn't the right word, but like recently accepted disorder? Like,
I don't think so. It has been around for quite a long time. There's been a lot of research done into it, but I guess the current research and the current sort of thoughts about the disorder have been more recent, so from the 90s and on. But I think one of the big things that changed the awareness of it, and one of the things that I'm sort of really advocating for, was in the DSM, so the manual that people use to diagnose mental health conditions. When it changed edition from the 4th to the 5th edition, OCD had previously been under anxiety disorders, and it was then taken out of that classification into a different one called OCD, or Obsessive Compulsive and Related Disorders, because there was more and more evidence that those conditions, so OCD, body dysmorphic disorder, body focused repetitive behaviours like trichotillomania, where you pull your hair, or dermatillomania, where you pick your skin, and hoarding disorder are discrete, conditions that aren't under that anxiety umbrella. And
so OCD falls into those?
Yeah.
Right.
Yeah. So
okay.
it's OCD, body dysmorphic disorder, BFRB is hoarding disorder.
What are some types of anxiety disorders?
So anxiety disorders can be things like generalized anxiety disorder. They also have phobias sort of under that kind of umbrella as well, and things like social anxiety or panic disorder.
Right. Do you know why it was taken out of that category and put into the other?
Yeah, because they were sort of seeing more and more from the data that they were getting that there's different parts of the brain that are involved with those conditions reliably, and it's different to anxiety. And the treatments for them can be a bit different as well. So it was just understanding the conditions more to then be able to recategorize what they actually are. And so when you think that the DSM-5, which is our current version, I think came out in 2013, so that's still pretty recent in the grand scheme of things. The funding, especially in Australia, the funding hasn't followed that sort of distinguishing it out of anxiety disorders. And so that's why, that's contributing to why we're really behind in Australia in terms of the support for OCD and related disorders, because there's no funding for them. There's funding for anxiety disorders. And I'm sure we benefit from some of that, but there's nothing dedicated to OCD and related disorders.
Right. So the NDIS plans, they don't help out.
No, and look, I think
it's crazy because if you said they're like one of the most it's a word I'm not going to try to pronounce.
Debilitating,
Yeah,
disabling.
Yeah,
and it's so. I think that brings in this huge, broad societal misunderstanding of OCD and its significance. So even people who are disabled with their symptoms might have real difficulty accessing NDIS, because when you know more about OCD, it's actually a really treatable condition. And so it doesn't have to be a disabling condition for most people. And so sometimes it doesn't get the funding for an NDIS support either, unless there's other sort of comorbid conditions that are what the primary funding is for, and you just happen to have OCD as well.
Right.
Yeah.
Interesting. We'll definitely go down the treatment bits a bit later, but I want to go back to the misconceptions of OCD, because it's the first time I heard of it, as I said at the start, was it's very loosely thrown around, and it's when they're talking about having things neat and tidy or color coding their pens or books or whatever, it's that's just my OCD. But that is incorrect. What are these misconceptions of it?
I think if you go back to what underlies OCD, that's where the real sort of disconnect is. So OCD is about fear and about doubt. And so having my pens organised neatly or having a colour-coded, organisation system is not based on fear or doubt. It's based on pleasure. I like having this looking neat, or I like having this lining up. And so if it is OCD based, it is because if you, for example, haven't got something arranged in a certain way, there is a negative consequence that doesn't have to be a logical consequence, but the parts of your brain that are overactive are treating it like there's an alarm system going off. And so it's not fun and it doesn't feel good. And so I think a lot of the time, when people make offhand comments about they're so OCD or it's okay to have a little bit of OCD, there's a real misunderstanding of what OCD actually is. It's sort of not a quirk, and it's not, a preference. It's a disabling disorder, and it feels terrible. And it's really difficult, one, in the moment if someone says they're so OCD because they whatever, to then have enough sort of capacity to educate as well and sort of say, that's actually, an example maybe of, being highly organised or having perfectionistic traits. And because it feels good, it's not OCD. So, yeah, there's a lot of misconceptions. I think there's a lot of, offhand comments. There's a lot of not really understanding what's happening for the person who has OCD. There's no way to switch off this alarm just because you want to. And so sometimes people will want you to not have OCD. And believe me, if anyone has OCD and they could switch it off, they would. It's not a fun experience at all.
No, I've experienced some personal stories with you about it. We'll go to in a little bit, because I do want to speak about how does that impact the daily lives who live with it, and feel free to speak about your experiences, and also the families or friends and families around.
I think one of the things in terms of that understanding about OCD, which then ties into all of that, is understanding why our obsessions are obsessions and why we actually struggle with them so much. And so there's this concept that our obsessions are ego dystonic. So that means that they're completely the opposite of what our real values are and what our real self is all about. And that's why when we have an intrusive thought that doesn't sit well with who we are, and we have this doubt and we have this fear, that's why you stick onto it and you go, that's not what I want. And you're trying to do things to help relieve your distress that's associated with that. So I think that's one of the big things that people need to sort of understand about the disorder, and that when we're really struggling with something, it's because of that mismatch with who we are as a person, at our core, and what is happening in our brain that doesn't sit well.
Right.
And so I think that can be really difficult for people to understand. And one of the ways that I was explaining that to my husband sort of early on in the process, the perfect example of it, which I tell to people that I'm talking to about OCD and my patients and stuff as well, is I give them the example of when we were camping. And it's such a good example. So imagine, I'll give everyone a bit of a background.
Yeah.
We went camping on the South Coast.
It was a research trip.
It was great. It was for educational purposes.
Exploring estuaries, which was,
Kurt was planning out sort of ideas for future research and that sort of thing. And James, my husband, who was his honours supervisor.
Right. And my boss.
And your boss. We all went down, and I think it was during like COVID lockdown time, but where we were allowed like to travel within WA. So the end of 2021.
The end of 2021, we were allowed to travel everywhere, which I can't. It might have actually been in November when we did it.
Yeah.
Because that's when there was still the lockdown, and we had the permits. No, we went after the lockdowns.
Whatever we were allowed to do what we were doing, I promise.
Yeah. We did have permits and the
everything was
essential research, or essential work permits to travel through borders. But I think
we didn't need any of that by that stage.
No, so I think it was after all that.
Yeah. Okay.
Anyway.
Maybe edit out the COVID-related lockdown parts. We were being very good children on the South Coast. And so the example is trying to like have people understand what the fear feels like. And it's really difficult if you haven't ever sort of had an opportunity to think about it like that. And so the example that I give people was like we're down camping on the South Coast. We were staying at Whalebone Beach in the
Whalebone Creek.
Yep, Fitzgerald National Park. It was a really hot day. It was like 40 degrees.
I think, yeah.
And because it was a work trip, you guys had been checking out estuaries for like a week and a half already, and I'm not a marine scientist or as interested in estuaries as you and James are. And I'd also been a little bit unwell. Like I was,
you were quite sick.
Yeah, I was just not loving sleeping in a swag by this stage. And so I'd said to you guys, I'm just going to stay at this cabin thing.
It was one of the hikers' lodges.
Yeah. And I was like, I'm going to stay here. I'm going to read my book. Go look at your estuary. I'll see you later. And as James was heading off, I said to him, hopefully no one murders me. Well, that was the little inception, apparently.
So is that an intrusive thought?
No, that was just me saying it.
Okay.
Because I have a very active imagination.
Yep.
It's James experiencing what an intrusive thought feels like. So I said offhand, hopefully no one murders me. I thought nothing more of it until, 20 minutes later when I heard a car coming up and thinking, oh my gosh, no one is supposed to be out here. We're pretty remote. Maybe someone is going to come and murder me. But it was you and James coming back, and it was because James took on board my off-the-cuff comment about hopefully no one murders me. And you guys came across some people driving on that road and they'd wondered if there was any decent fishing where you'd come from. James said that he deliberately pointed them in a direction away from where I was. And you kept on driving for another 5 minutes or something, and he just said, you have to take me back because he couldn't live with the fact that I'd be murdered by those people if I were going to be murdered by them. And, spoiler alert, wasn't murdered by the people, but that was James's experience of that intense fear, and getting you to turn around was the compulsion. So he couldn't stop thinking about, I'm going to get murdered by someone. It made him really anxious. And the way that he needed to reduce that anxiety was to go back, which is the same cycle as what happens with OCD. And so...
But he doesn't have OCD.
He doesn't have OCD. But it was more like a way to demonstrate to people an example of something that is the same process and causes so much fear and so much distress. And that's what we're sort of managing. For me, every waking minute, OCD is there.
So when you're at home, what are like some of the things? Because I don't know if this is a misconception or not, but like making sure the lights are turned off or the stove, like always worrying about the stove was left on or something like that?
So I have a lot of different like subtypes of OCD.
Subtypes, so there's different types.
There's heaps of different things. Think of anything that you really like, OCD can get stuck on it. My main ones are about contamination. They're about harm.
Contamination, is that a plus side being a doctor?
No.
Right, okay.
It's a lot of the times when you're like you have a contamination obsession that's associated with OCD, it's often not logical and it's not necessarily like a helpful function. So no, it's very unhelpful.
Okay.
But so yeah, I've got contamination stuff, I've got harm stuff. There's some sort of more taboo things that are like violent intrusive thoughts, or there was a really brief period that I'm very glad I knew what was happening for me, so that one of like the really taboo things didn't progress. And so that was about a pedophilic intrusive thought. And so the thing that is really important when we talk about OCD and the specifics of it, which I'm very happy to talk about, is always going back to the underlying, it's ego dystonic. It's the opposite of my values. And so when I have, a difficulty, I'll give you one of the sort of at-home examples. I'm not necessarily turning light switches on and off, but I do have a thing about the iron, and it's because I'm worried if I don't unplug the iron, the house will burn down, which seems like, a relatively logical thought process. But the next part of that, which is the OCD part, is that I get intrusive images, and it's kind of like I can even hear things in them. So my house isn't just burning down because I've left an iron on. My dogs are in the house and they're very distressed because they are dying in a fire, and I'm seeing it and hearing it and experiencing it and can't do anything about it. And so I don't want that to happen. So should I go check that I actually unplugged the iron so that I don't have to, experience that? That's one that I still...
Do you check it over and over again?
Yes, as a compulsion. So
this is the difference between obsessions and compulsions.
Yeah, so the obsession is like the thought or the image or something that's sort of cropping up for you, and it causes anxiety. And then the compulsion is like doing something to try to reduce that anxiety. And it does in the short term. Like James, when he came back to make sure I wasn't murdered, his anxiety was reduced because I wasn't murdered. But because he doesn't have OCD, that was the end of the thought process. Whereas with someone who has OCD, you're never satisfied with knowing that it's okay, because there's always a little tiny chance that something might still happen, that you can't have that certainty. And
so what do you do next?
Well, if you don't know that you have OCD and you don't know that what you're doing is a compulsion, you do get temporary relief from doing the thing, but that ultimately fuels the disorder. And so that's when we'll talk about treatment of it. You have to not do the compulsion, and it feels awful. Yeah, because you've got this alarm going off in your head telling you that you have to do something because there's going to be this negative consequence if you don't, and you have to choose not to do it and then sit with, the feeling that the horrible thing is going to happen. Most of the time it doesn't happen, and then over time the anxiety will reduce. That whole cycle sort of calms down a little bit, but it's really hard to do. So one of the things that I have at home as well is about like harm to do with with James. So these are things that I don't want. So obviously I don't want my dogs to die a horrible death in a house fire. I also don't want to murder my husband. And my brain will come up with all sorts of creative ways to wonder if I would do that. And because it's ego dystonic, I don't want to do it. Those thoughts are sticky and they come back. And then before you're...
So there's sometimes thoughts of murdering James.
Yeah.
Do some people turn into murderers?
No. And that's the thing. Like, we are so bothered by an off-the-cuff thought, and people have intrusive thoughts. Everyone does. So if you were cooking with James in the kitchen and you were chopping something with a huge knife, you might have a thought that goes like, I could probably stab James with that. And then you go, that was a weird thought, moving right along. And that's the end of it. Whereas there's funny chemicals and funny electricity going on in my brain that goes, why would I think something like that? Am I a horrible person? I must ensure that I don't murder my husband. So what I will do to reduce that risk is he can't come in the kitchen when I'm cooking. I can't talk to him when I'm cooking because I need to concentrate on not murdering him. You kind of set up all of these things in your world to reduce the risk of doing.
Is that the compulsion?
Yeah.
Right.
Exactly. And so avoidance is a compulsion, and I used to do so much avoiding.
Yeah, right.
Yeah. It was in learning about what OCD looked like for me and not doing compulsions, I realized just how much of my life was spent doing compulsions and like doing OCD. Yeah.
I've experienced avoidance with living with someone. Is it similar, or can it be confused with other types of disorders?
Yeah, it definitely can be similar and confused. So one of my biggest sort of contamination things, sometimes if your intrusive thought is related to like disgust as the underlying sort of mechanism, that can be really difficult to sort of manage and to get on top of. And so one of my really, like my worst sort of theme really is disgust based. And so that's what I struggle with the most. Initially, we wondered, is it a phobia? Is it something like, there was a really specific thing and it was like about an infestation. And so my psychologist and I were wondering, okay, is this a phobic sort of disorder with this? And then when I was more concerned with general like life things, we thought, is this generalized anxiety? Like, is it just really extreme worry about day-to-day things? And there's other stuff that sort of crops into it as well. So, people with autism doing stimming behaviours, they're a repetitive sort of ritualistic behaviour. Is that a compulsion? You have to look
what
at
are those? Sorry.
Stimming.
Yeah.
So like tapping or moving things or, anything that's like a sensory thing. So it can often look like a body focused repetitive behaviour, for example, like when you're sort of picking at skin or that sort of stuff. And so you need to look at we always say like WTF, what's the function of it? Like, is it for easing anxiety or is it something that you do because it feels good? So are we rocking back and forth because that is something that is helpful for emotional regulation, or is it because we have to rock back and forth 20 times because if we don't, I don't know, something bad will happen.
Yeah.
I'm thinking all the wild things that my brain will come up with. And so it can be often sort of confused or difficult to diagnose. There's a lot of people can get disordered eating things like ARFID, which is a restrictive sort of intake, and it's a sensory sort of thing with it as well. And because of all of these rules around OCD, you can be, misdiagnosed with an eating disorder, but because underlying it is this sort of different process, it might get missed because it's misunderstood. But that being said, there's so much overlap as well. So you can have OCD and generalized anxiety disorder. You can be autistic and have OCD. You can have all of the above, essentially. Like there's nothing to sort of say that that's not happening for someone. But it is really complex, and clinicians need to be really skilled to be able to tease those things out. And so it's a sneaky one. It gets missed a lot.
Yeah, I can imagine so. Is it like, how is it typically diagnosed? Is there like key criteria?
Yeah, so we've got that sort of DSM criteria, which is what you have to sort of tick to be formally diagnosed with OCD. And to get to that formal diagnosis, you'll be kind of reviewed by someone who really knows a lot about OCD and other conditions. So one of the most commonly used screeners is the YBOCS. So it's the Yale-Brown Obsessive Compulsive Scale. And that is like 64 different questions about obsessions and compulsions, as well as a rating of like the severity to which you experience things.
This can be like an online test if people wanted to self-diagnose?
You can self-administer it. It doesn't do a whole lot if you're self-administering it.
No.
It's more kind of to know, one, is it suggestive of OCD? Two, what sort of severity OCD is there? And those, like, there's heaps of screening things that they use for different things. Like there's a CYBOCS, which is the children's version, or there's shorter screening tools that are sort of for use where maybe you want to know if it's worth looking into that further in a school setting or something like that. But yeah, it doesn't need to be diagnosed by a psychiatrist. It can be diagnosed by a psychologist, or even a GP that's, quite confident that they understand what's going on. So there really shouldn't be barriers to diagnosis. It's more that education piece, that we all need to boost within the entire community to get it on the radar for people.
Yeah. What are some of the early signs of like OCD in, say, children or teens?
They can be anything. So I think for children, so there's sort of these peaks where OCD symptoms will come up, and it tends to be sort of between 8 and 12 years old and then into the teen years as well. And it's any sort of like repetitive behaviours that seem a little bit unusual, or repetitive questions that keep coming up that so what people will do as a compulsion sometimes will be reassurance seeking. And so a parent or a teacher might notice a child asking a question or asking for reassurance, but because of that part where we can't tolerate uncertainty, if there's a teeny sliver that the bad thing could still be, there, that's why that repetition, because it gets stuck in a cycle. So anything that's sort of repetitive, you kind of want to go, what's happening there? Or, if we definitely like have a rigidity thing as well. I'm super rigid at times. And so when there's a change in plans or anything like that, that might just be way too overwhelming. And so that could, people could be having like a meltdown or a tantrum or shutting down or something like that. And it really is because of what's happening under the surface of that needed to be that way because, and now that's not that way, this will happen, or I'm worried that this will happen. So yeah, it's that fear, it's that doubt, intolerance of uncertainty, lots of repetition. Even things like difficulty concentrating. So if you imagine you know that thing that we used to do where you had to like tap your head and rub your tummy?
Yeah.
And then like do it with your other hand. I can't do it that way. It's like doing that and doing a test at the same time. Like your head is doing more than one thing and it's really exhausting. So it can be, you know, you're distracted in class because you're doing compulsions, but they're not necessarily like a physical compulsion. It might be something that you're doing in your head. Or you might have difficulty concentrating because you're so distressed by what you're experiencing that you just can't do anything else. So
what about like if you're doing something, like fixing something, working on something physically with your hands, and then someone's trying to speak to you and you just like
instant rage? I feel like that's maybe more my ADHD.
yeah. But or what about like you just don't listen to them? Like it just goes over your head. You just don't hear them.
I think it's so hard for me to say what's what because, you know, that complexity of stuff. I have other things as well, and I don't know if that's OCD or ADHD or autism or something else going on for me. So I sort of couldn't say for others, but it's definitely like if you imagine we've got a certain amount of bandwidth for our brains to function, and you're already, you know, working like a normal person would in terms of, you know, the range that they've got, but then you've got this huge volume of thoughts that you're trying to filter. And then if you're really sick with OCD, it's so hard to filter. And you're doing that at the same time as you're doing all of your normal things. So I don't know if they're like, you generally, like your executive function is impaired. And so depending on the individual, you may not hear that disruption or you may not process that disruption. But yeah, I have no idea. It's so difficult.
Yeah. You mentioned earlier that you felt like you've lived with it your whole life. Is it a genetic or a product of your environment?
Bit of both.
Bit of both.
Yeah. So there's definitely, we know genetics-wise, there's different sort of genes that are linked with OCD. They tend to be linked with our like serotonin, our glutamate and our dopamine sort of systems within our brain. And we also know from like, you know, twin studies and that sort of thing, that there's definitely a heritability sort of aspect to it.
What do you mean with the twin studies?
Yeah, so when they do twin studies and they'll look at like identical twins and see, does someone develop this, does someone develop that? And it's a way that they've sort of used to sort of look into genetics. So I think I wrote in my notes, I'll preface everything with not a geneticist.
Yeah.
But yeah, there's definitely sort of heritable parts of it. And I think the current sort of research, it's got a big range, but anywhere between like 30 and 77% heritability for OCD. So if you have OCD, highly likely someone in your family that came before you has OCD. And a lot of the time when I've been sort of speaking with parents who are trying to help their kids who are sick with OCD, there's a lot of anxiety in that cohort. And even, you know, sometimes I'm looking at people and I'm going, oh, that's a bit of a pattern that I've recognised. So, you know, we're also helping parents figure out that maybe they also do have a diagnosis of OCD. Sometimes you can have symptoms of OCD but not have them clinically significant, so you're not actually meeting diagnostic criteria. So the time consumption part of it is at least an hour a day. And so you can still have like subclinical aspects of OCD without a formal diagnosis of it, or you can have like OCD that is not currently active, like clinically active.
And is that how it can get passed down?
Yeah.
Is it, you said it's like also partially your environment. So can you develop OCD in later in life?
Yeah, absolutely. And so the reason that one of the reasons there's this sort of distribution times when it's more apparent are interesting stages in terms of our development. So as we're 8 to 13 years old, there's lots of things happening, and there's definitely a peak then in when people present. Also sort of into adolescence and then even into early adulthood. And that often is when you're increasing your capacity in terms of what you're doing. But because of that, you're not able to sort of manage other things as well. So instead of masking a lot of the symptoms, that might be when they emerge. And there's definitely, in terms of environmental things, there's a really close association with trauma and OCD and trauma and PTSD. And they're doing research in the States at the moment about what came first for you. Like if someone has PTSD and OCD, which was their first? Do they think one triggered the other? Do they think one made you more susceptible to the other? And I think the numbers there of people who have OCD who also reported trauma, like I think it was 88% or something like that. So huge link to trauma. And
was there certain types of trauma? Like what's
anything? And it's because everyone's so unique, whatever you're like, you can have any sort of traumatic experience. It doesn't need to result in a diagnosis of PTSD. It can be like something that is traumatic that just is what you needed to trigger the condition to really take off, which was kind of what happened for me.
When did you first realize you had OCD? Like
pretty recently.
Yeah.
Kind of embarrassingly so. So for me, I remember my first sort of OCD symptoms when I was 3 years old, but I only just now know.
You can remember when you were 3?
Yeah.
Wow.
I'm very smart.
Yes. I didn't know that.
No, it was because there was something happening at the time that was really significant. So my brother had open heart surgery when he was 4 and he's a year older than me. So I was 3 and I remember going to the hospital to see him after his surgery. And I couldn't pick a balloon. I was allowed to select a balloon from the gift shop at Princess Margaret Hospital. Couldn't pick that balloon, and my parents, who didn't understand it was OCD or didn't understand what OCD even sort of was then, thought that I was being difficult because I wasn't getting attention, and my brother was because he was in an ICU after having open heart surgery. And it wasn't until it was last year my mum heard for the first time, I couldn't pick the balloon because if I didn't pick the right one, my brother was going to die. And so there's 3-year-old me not able to actually comprehend that doesn't make logical sense, but also not knowing how to communicate that that's what's happening in my head as well. So yeah, that was when it all started, or at least that was my first recollection of OCD, and it's that sort of harm theme. But for me, the diagnosis didn't come until 2022 when I was 33. So, 30 years worth of symptoms and distress was awful. The reason that the diagnosis sort of finally came was because I had a trigger, and it was a trauma trigger, and my previous pretty much not observable or just mental compulsions that I was doing, so it was all very much internalized, for the first time there was like an outward component to it. And so I was doing a physical compulsion that you could see. And it was what we needed to like piece together. Okay, it's not a phobia. It's not generalized anxiety. It's actually OCD. And it's because I think for my entire life, out of necessity, I internalized so much, I masked so much that not even I understood what was happening. Yeah. So I was doing a job that wasn't my favorite, and it was an hour commute either way.
This is, yeah.
And silencio. Driving an hour to and from work I wasn't supported by my supervisor, and I felt really uncomfortable in the environment. And what happened one afternoon was a patient came in and they were really angry, and they were being really awful to the receptionist and the cleaner. And I overheard what was happening, and so I sort of said, hang on a second, you can't behave like that in here. And the person then targeted me and assaulted me, and I felt so let down by my employer, who was my supervisor as well, because they allowed it. And afterwards, when I raised issues about safety and why this was a concern, it was minimised. And so that experience and the trauma of that at a time when I was really quite vulnerable, because this had been sort of worsening in the background. That was really the trigger, because it was within a couple of weeks. I think it was like less than 2 weeks. I found myself in my room at the clinic knowing there's a patient waiting to see me, and I couldn't stop washing my hands. That was what my compulsion was. I was just on this loop of washing my hands, and I couldn't stop until it felt right. And I didn't know what it was going to feel like when it felt right. And I just knew it didn't. And I remember feeling so frustrated with myself, thinking like, stop washing your hands.
How long were you washing your hands for?
I think probably about 10 minutes before I managed to just stop. But yeah, like you just think, I'm an adult and I'm independent and I've got a good job and I've got like heaps of qualifications, and there I was standing at a sink and I couldn't stop. And now that I know more about OCD and how it presented for me in so many different ways, like you can't unsee it once you're seeing stuff, but that was really, how it first sort of really showed up in a way that then led to the diagnosis.
Is these part of the reasons why, it kind of obviously is why you started founding OCD WA?
Yeah, I think a big part of that diagnosis, so that was sort of around April 2022. And then I did so much research into OCD to understand it. In starting to understand it and starting to identify things, everything just went completely off the charts in terms of the severity of it. My first Y box that I ever did put me in the extreme OCD category, so beyond severe into extreme. And yeah, like being really unwell with OCD, recognizing what it is, and then kind of dealing with like a big flare in symptoms at the same time. Trying to find help for myself, trying to find my peers to be able to talk about it. They were really, really difficult. So the type of treatment that is the gold standard isn't taught I didn't learn anything really about OCD in med school. I did a job in psychiatry, didn't learn anything about it. Worked in ED and sent people to the mother baby unit with what I thought was perinatal depression. It was probably perinatal OCD. So like I've probably missed it so many different times in my career because it wasn't on my radar. And then, to be able to have open conversations about what you're experiencing or like these taboo things that if someone didn't understand the process would be wanting to potentially lock you up. It was that kind of disappointment really with the system that why aren't we picking this up? And isolation and like a feeling of sadness with that isolation that I want to talk about this because it helps to minimize and to reduce the symptoms, but also finding safe spaces to be able to openly talk about it didn't really exist. And so it was in having conversations with some people that I'd met like early on in my journey about I want to talk about this and I want to improve access for people. And there's lots of different things happening like in the country and around the world, but it's not necessarily like coordinated. And so it was at a time when I was like my most unwell, so almost bedridden, not quite, almost. But I just thought, you know what, I can see what needs to be done. I've got the skills to be able to coordinate some of that. I've definitely got the drive to like keep that motivation on to do this and to do the hard yards to get it there. And I think that was my big sort of, I don't know, idea from the like really early stages. And I think just the frustration of knowing how different things could be. And I think especially reflecting on how difficult things were for 30 years for me, like I don't want other people to have to experience that. And so I think a lot of that drive was then just like, putting my foot down and digging my heels in and being like, well, this isn't okay and we're going to have to fix it.
So is OCD WA like to help like general public, or is it to help GPs and psychologists and psychiatrists help identify it and diagnose it and be aware of everything?
Yeah. So first and foremost, it's for people with lived experience of OCD and for their support network.
Mm-hmm.
So for me, peer support was a really big thing that I felt I needed early on. And so that's really like the first big project that we got up and running because it is so valuable. But alongside that, I'm wanting to get out education for everyone. So general population, people with OCD, their support network, clinicians, so GPs, psychologists, psychiatrists, educators, like because of the big peaks in symptoms that are during kind of schooling ages or early adulthood where people might be in universities, to have educators more aware of it so that if they notice any of those little things that we'd mentioned, like if there's a recurrent question coming up or if there's some unusual behaviours, not necessarily to like be full ball and be able to diagnose it, but to at least have enough sort of background knowledge and have it on your radar to go, I wonder if they need to kind of look into that. Because what we would have, and the number of times in my life I've heard like that was just your personality quirk, or that was what does someone at work says excuse me. What did she say? like, no, I can't remember the word now, but like wacky or something like that. Like these people have these sort of traits and they're kind of similar, and it's, yeah, so strange to tell someone, yes, especially when I got diagnosed with ADHD, saying to someone who had been an educator for me 17 years ago was like, well, yeah, you've got ADHD. And I'm like, I didn't know that. Did you want to like suggest it or bring it up at any stage? Because it might have made med school so much easier.
Yeah. How well, I know you went to San Francisco for like OCD workshops, so that's like, it's definitely the awareness of it's growing and learning.
Yeah. Yeah. So in the United States, they do a lot of research on OCD. They've got really good like systems for OCD there. They're not ideal. They're not perfect by any stretch of the imagination, but there is so much more. So you can find a clinician who is OCD informed relatively easily. You can have intensive outpatient treatment relatively easily. You can have inpatient treatment relatively easily. Comparatively in Australia, in Western Australia, there's a handful of clinicians that I think are really up to speed with OCD treatment, and 5 clinicians for 100,000 people's not a good ratio. There's also, we don't have intensive outpatient really. We don't have inpatient really. The only clinic in Australia that's got inpatient specific to OCD is in Melbourne.
So these are the types of treatments. I don't know the differences between those types. What are the treatments for OCD?
So there's a few different things that have evidence behind them. I've been really happy at the end of last year, so December last year, the Australian Psychological Society put out their review, which was for, all of the evidence for different treatment modalities for different conditions. And it's the first time ever that it said there's level 1 evidence for exposure and response prevention for OCD, because previously it had said like CBT, which is a type of therapy, but it's that qualifier of exposure and response prevention therapy that is going to make such a difference, because people could historically say, come see me for your OCD and I'll treat it, and have absolutely no additional training on managing OCD. And that can be harmful, like not even not helpful, it can be harmful.
Right, exacerbate it.
Yeah. And so in terms of what that looks like, so there's level 1 evidence for ERP, acceptance and commitment therapy as well, which is sort of an adjunct therapy that's kind of like self-compassion and mindfulness. And it's because we have so much shame and guilt associated with our OCD that we have to sort of be more accepting of that and be less self-judgmental and less self-critical. There's a different type of therapy that has increasing evidence for it at the moment, that's called inference-based cognitive behavioural therapy. So it's just where we have that OCD anxiety cycle, it's just managing a different part of the cycle. There's like, it's sort of you're not reading into whatever the intrusive thought is, and therefore nothing comes after it. But what ERP, which is, the gold standard treatment, looks like is really cataloguing what your OCD is, what the themes are, what the underlying fears are, and why they come up for you. So my core fears underlying everything are really about my own safety, my own physical safety, and about abandonment as well. So like if my safety and fear of, being abandoned are underlying all of my thought processes, that's kind of what it's aiming to get to. And so you're, with your clinician, you're cataloging all of this stuff that comes up for you. You're writing down what obsessions you have. You're writing down what compulsions you have. And then with your clinician, you're making like a hierarchy of what can I do to mess with those compulsions, and eventually stop those compulsions so that I stop feeding the cycle. And so one of the ways that I've explained ERP to people is like, imagine you're standing on the edge of a skyscraper. You've been told that there's a safety net that'll catch you, but you can't see it. And you just have to have faith and take the leap. And it hopefully works.
Right. So that's like talking and going through the process with like psychologists, or what about medication?
Yeah, so medication, when we say like the gold standard for OCD, it's ERP, that therapy, plus or minus SSRIs. So selective serotonin reuptake inhibitors are like the most widely used medication. There are some other medications that can be used, and you'll notice it's sort of a plus or minus. So ERP always. Or
for everyone? Is this ever like depending on the person?
It can be, and like everything, treatment for everyone really should be individualized. So for me personally, like I've had elements of ERP. I've also had elements of ICBT. I have ACT, which is the acceptance and commitment therapy. That comes into everything. And I've also had like trauma processing stuff that I did before I started ERP as well. So because the way that our OCD comes about, we also like really need quite nuanced treatment to get on top of everything. So yeah, I forgot where I was at. Yeah, ERP plus or minus SSRIs. So, and that's current gold standard. It can change. That's what the evidence says is the best. You're always going to be needing that sort of therapy component. If you do the therapy component and you're needing medication, that is really effective. If you're not needing medication, you're doing the therapy, that can be effective as well. People might, it's in the education piece, they might not understand about the therapy part and they might want to just do medication. That's not going to undo those processes on its own though. Like you have to do that hard work. So it's quite complex. It's definitely got personal choice coming into it as well. Like even this morning I got contacted by someone who's thinking about going on medications again and wanted to sort of get a little bit of, lived experience advice about whether that might be a good idea. I think it's so individual. So for me personally, in order to start doing ERP, I just felt like I had so much going on that if I needed medication, I'd rather try it to make that process easier. And so I've found that, especially with mood things, like that helped to stabilize my mood to give me enough headspace to then really jump into the therapy. And so me personally, I'm on an SSRI, and for OCD, you typically need like high doses. So the doses that people would have for depression, quadruple it. Like that's the dose that you're on often for OCD.
Right.
Yeah.
Wow.
So you need a really high dose. Yeah.
Well, how does drugs and alcohol affect people with OCD?
I was thinking about this beforehand. So I think if you're taking drugs or you're drinking alcohol, sometimes it can make the symptoms like feel a little bit better because you've got that, like you're not necessarily caring as much.
Yeah, numbing the effects.
Yeah.
Okay. Even like, I know there's drugs is a very broad term because you've got the depressants and stimulants and all those different types. Like, would it be different from like someone that's like a meth addict to a?
Yeah, I can't imagine what someone's
those intrusive
thought
thoughts
processes would be doing.
No, yeah.
Yeah, so it's interesting because I feel like drugs and alcohol potentially like suppress a little bit of the experience, but also they're not like a precursor to developing this. So, you know how sometimes people might get like a drug-induced psychosis where, you know, they've taken a drug and it's very clearly linked to the onset of something. That's not typically what happens in OCD. It's kind of the other way around. So people who have OCD might develop substance use disorder and have too much alcohol or take recreational drugs in, you know, an unhealthy way as a way to manage the distress that the disorder is causing. So there's definitely a link with substance use disorder and OCD, but it's more coming after the OCD rather than causing it or there's something underlying it.
Right. So say when, let's say like come downs and stuff, would that exacerbate those things? Because like if you're feeling low or depressed.
Yeah. Well, and
what about mixing? Sorry, and I'll add on to it as well. What about like the mixing with these medications?
Yeah, I think it would really depend like what someone was on in terms of their prescribed medications, what they were actually taking in terms of a recreational drug. It's not an area that I've had a whole lot of experience with. But yeah, I can just, knowing what my OCD is like and how so much of it is about control, yeah, I could just see things going completely awry. And, you know, maybe that's part of the reason that I don't know a whole lot about recreational drugs because there's definitely parts of me that I know, for example, I've got like a really addictive personality. So I'm not going to go near something that's potentially addictive because I feel like I'm highly likely to become addicted to something. And so it's the same because with obsessive compulsive and related disorders, like I've got OCD, I've got dermatillomania and trichotillomania. I definitely have the right chemistry and signals going on to develop a hoarding disorder. And so I'm aware of that. And
what are those two that you just mentioned? Sorry.
Skin picking and hair pulling.
Yeah.
So I'm conscious that I don't want to start doing anything that could progress into a hoarding disorder because I know that I've got that wiring primed for it.
Right.
Yeah.
Okay. And is an addictive personality like a trait of OCD or
no?
It's just
It's just something I know that I have in myself. I think there's you know, one of the things I had experienced when I was younger was binge eating disorder, and it was because of the feeling, like the good feeling I got from eating something, but overeating to the point where I made myself sick because there wasn't like the stop mechanism for it. And so because I'd experienced that, that's why I have those, like, I don't know if I would become addicted to something or if I would develop hoarding disorder, but I just know that for me, I don't want to know. And so I'll just steer clear.
What are some like red flags people should be aware of when they're speaking to a clinician or any type of what should I be meaning by a clinician, like GP, psychologist, psychiatrist, or all of them?
Pretty much anyone. In terms of red flags for clinicians who are going to be delivering the therapy, I think that's a really important person to like feel comfortable to ask questions of their knowledge and understanding, because we don't get taught enough about OCD, either in med school, when you're studying psychology. One of the people that's on our board is a psychologist and is really interested in OCD, and made the comment that OCD is always you'll learn about that later. It's a more specialized thing, but later never came. And so there's a real gap in knowledge. And so I think if you know that you have OCD, that you're wanting to see someone to get that therapy, I want to know what that person knows about OCD. Like, have they gone to like any institutions that are really great quality OCD?
But what if you weren't aware that you had OCD?
Well, then you don't know. You'll just be compulsing all over the place and you won't know.
But like if you're going to a clinician, like if you think there's something going on and you want to like I'm just like my brain's different to other people, and you go see someone, what are like?
Oh, like red flags for clinicians to see, you mean?
Yeah.
Yeah, it's like repetitive things, like extreme anxiety that seems like in excess of what it should be, or fears that aren't necessarily logical in like the process. And that's why it can be really difficult to pick up, because one, it's not on our radar, but two, it's kind of like pretty unique and weird and unusual, and you really need to know what's going on for someone. And because of the stigma and because it's sort of misunderstood, sometimes people don't want to disclose some of like the really shameful parts of it, because they're worried about what the clinician's going to think, especially if they don't know what's happening. Like, perfect example of this, I was at work one day and I knew I needed to drop my hours. I knew I had OCD by that stage, but was in the process of getting on top of managing it. And the first thing my boss said to me is, have you got any thoughts of self-harm or suicide? And I said no, which wasn't the truth, because I have suicidal OCD. I constantly think about suicide, but because I didn't think that they understood the concept of ego dystonic, that's the last thing that I want, that's an obsession for me because of how misaligned with my values it is, that I'm probably the least likely person to actually do that. But because they don't understand that, they probably would have sent me to an emergency department, which is not helpful for me at all. Yeah.
It's kind of confusing when you're saying that, like, you have the suicidal thoughts, but you won't act on them.
Yeah, because so that's the difference. This is an interesting one to sort of get your head around as well. So suicidal OCD versus suicidality. Suicidal OCD is ego dystonic. Suicidality is ego syntonic. So if somebody wants to end their life, they have a plan, they are going to be doing it. That's something that they want. Whereas if someone with OCD, we're fearful that we might do that. And so we're going to do everything we can to not do it. And so that's why when we say, I've got violent obsessions, I've got taboo obsessions, you're not going to act on it. You're doing so much to try not to have that thing happen. So that's why, like, they're completely different, but you really need that extra level of understanding to know that that's what it is. And that's why, finding your peers and being able to have those open conversations and having clinicians that understand is so important, because, can you imagine, opening up about all of these things that you've got and you'd be locked up? Like, I say to people, if I were born 50 years earlier than I was, I'd just be in an asylum, because we know more now. But yeah, it's really difficult. And I think in terms of red flags, there's so many different things. It really needs people to to understand what it is and to look beneath what everything appears like and to figure out, it's back to the WTF thing, like what's the function of this behavior?
And what we started talking about in that part was like, how do you choose, like a red flag for a psychologist? So if you're going to choose someone to see, how do you?
That's why I clarified, because I was like, oh, hang on, we're looking at what is a red flag for someone who might be diagnosing versus what is a red flag for someone with the condition who is wanting to access treatment.
I think that's what I was trying to originally mean.
Yeah.
But then it was also interesting doing the other way as well.
So when people are trying to access treatment, what they need to sort of look out for and to know is, does their clinician know OCD? And a lot don't, because we're not taught it. For the clinicians who say that they manage OCD, what does that look like? Are they doing gold standard treatment? Are they utilising sort of the current evidence-based modalities? Because if they are, they're actually really effective. It's just that the access to those really effective modalities is not a lot, especially in Australia. So knowing like what someone's understanding of OCD is, what their experience is in treating OCD, if they've gone to any, specific educational courses on OCD and on ERP specifically, and for patients to feel empowered and know that you can ask a clinician, like, what is your experience in treating this? Like, someone who is offended by that question is probably not the right clinician for you. But, other things would be, from a patient perspective, if you're...
But this is like you're going to a clinician already diagnosed with OCD.
Yeah.
What about if, like, I think this is where I was trying to ask before, was like, you're unaware of what you're going for, like, but you want to get diagnosed. Well, you think something's going on.
Yeah.
Yeah, I guess it's just, you want them to be across, again, the simple answer was you want them to be across all different types of disorders. Yeah.
And there's just sort of a general lack of that. But one of the things I'd sort of been working on in GP land is like a tick box sort of thing that people can take in. So even if you're not sure how to describe what's happening, or if you're too frightened to actually disclose much detail, there could be something that you tick that's like, okay, well, these are obsession categories that I experience. These are compulsions that I do. I think I might have OCD, or, you kind of have to already think you have OCD to find that kind of resource. But then to take that to a GP and sort of be like,
should they be seeing a GP or a psychiatrist first?
Well, you can't see a psychiatrist without a referral.
Yes. Yeah, okay.
So, it'd be GP first. The other side of this piece of paper that I'm developing is resources for GPs, so that they then, this is a link to the Y box, and you can sort of do a general screen to see what the severity kind of looks like, or eventually I want to have a treatment pathway specific to Western Australia, of like, okay, GP sends this referral, and this is what the follow-up looks like. This is what check-ins sort of happen. These are the resources that are available. But it's all pretty early stages because we're building it from the ground up.
Yeah. How hard is it being a GP? Because it's like you got to know a lot about so many different things.
Yeah. And to be honest, I'm not a GP yet. I've got about 6 months left of training and my fellowship exams to do. And because I was overwhelmed with OCD, I've paused the training. So, it's in order to maintain my own health and sanity, I guess, I put the brakes on that. And I'm very open about that. I think it's the best choice for me, and I encourage other people to take breaks when they need it. But yes, being a GP or being a GP registrar, which is what I currently am, is really hard. You need to know so many different things about so many different things and try to kind of do a really good, complete job, which my OCD definitely creeps into, within 15-minute windows. It's nuts. Yeah, it's a hard job.
Oh, I can imagine it is. If you had unlimited time and money, what would be your dream project? Or what would you want to, I guess dream projects, but with the way to.
I think if I had unlimited time and money, like a big portion of the money would be going towards OCD related things. But then a big portion of my time would be about puppy dogs and relaxing.
Good answer.
Yeah.
Is there any specific in the OCD realm that you would focus on?
I think just all of the things that I'm doing at the moment within OCD WA is being done to set it up in a way that it will be sustainable. And so having more time and having more money to dedicate to that would make it a lot easier to do. But I'm also really happy with the progress that we're making and the structure that we've sort of put together because it will take time, but it's going to change the landscape for people with OCD in Western Australia, but also, into Australia as a whole. I kind of joke that, so our organisation, it's a fully fledged charity. We're also the one and only global partner organisation with the International OCD Foundation, and there's not many of those in the Southern Hemisphere. So I joke that we're kind of OCD WA, which is OCD Australia, and then kind of OCD Australia, New Zealand, OCD Asia Pacific, OCD Southern Hemisphere.
Right, yeah.
So, yeah, big plans for the future, but just kind of setting things up at the moment so that it will survive the long term.
It sounds like it's great work that you're doing and really raising awareness. And I know from today, even like this has been such an eye-opening experience and learning. Like I didn't know too much about it before until I started delving into the research of this and the links and stuff that you sent to me. I was like, oh, there's like, I had no idea about this stuff. So so thank you for coming in and talking. This has been awesome.
I enjoy doing, this is all advocacy, but, and thank you for having me. I wanted to say I have a bunch of students from Murdoch University who are psychology students who have come on with the organisation as volunteers. And I've run like an 8 sort of session education series about OCD to improve their understanding of it. Every single one of them has learned so much, has kind of understood like how fascinating a disorder it is. But I feel so excited that there's now going to be this, bunch of new clinicians coming out that already have so much more understanding of OCD before they've even started. And hopefully they all become OCD specialised when we're able to offer more and more education in that training piece. So, it's very, very big undertaking, but also incredibly rewarding and making a difference every day already.
That's awesome. Big steps forward. Well, thank you.
Thank you for having me.